Cardiologist, helping you not have heart attacks since 2019 when I launched Apollo Cardiology. Been doing a little bit longer than that. I've been a doctor since 2002, so not my first rodeo. Just got back from a AI and cardiology conference that the Mayo Clinic put on. It was outstanding. A lot of things that I'm going to be talking about in the next couple of weeks that Apollo Cardiology will be implementing now that I know some of the tools that we can utilize more than we've already been doing to screen for vascular health. One of the most interesting pieces of technology I saw was AI EKG analysis that can tell you if you have a weak heart, a cardiomyopathy in medical parlance. Also will tell you your risk of atrial fibrillation, which is a heart rhythm that increases your risk of heart failure, death, and stroke. And later it's going to have different features where it can tell you actually if you have cirrhosis. So super fascinating technology. Going to be bringing that to Apollo Cardiology as soon as I can get my hands on the gear. So no other housekeeping tonight. We'll got a couple questions that were pre-submitted. We'll answer those. And then I'll jump into the comments and answer those as well. So first question tonight, why is exercise good but high blood pressure bad? So it's not a either or. Exercise is good for multiple reasons. From a vascular standpoint, improves your cardiorespiratory fitness, flow across your glycocalyx. The lining of arteries helps the underlying endothelium release nitric oxide, which keeps the arteries elastic. Nitric oxide helps prevent cholesterol, lipoproteins, the white blood cells, the platelets from aggregating or sticking to the arteries. So exercise helps with lowering inflammation, good for brain-derived neurotrophic factor. So lots of benefits. But transiently when you exercise, it does increase blood pressure. That's a non-response. So I did thousands of stress tests in my career before I walked out of the hospitals. And that was the normal response. But there is a hypertensive response exercise that you're watching for. And some people may have normal blood pressure at rest, but they have a hypertensive response during exercise. They're more risk of having sustained hypertension at home. So those are people who want to start monitoring at home more frequently or have them wear an ambulatory blood pressure monitor. So transiently, exercise increases blood pressure, but long term, because of the shear stress, the arteries release more nitric oxide and become more adapted at it and keep your blood pressure normal at rest then. And then there's only one other pre-submitted question, then we'll jump into the comments. Somebody says that their echo, which is an ultrasound of the heart, their EKG, which is an electrical tracing of the heart's voltages, were good. They need to test for blockages. Can't have contrast with their thyroid. Is MRI enough? So I would need more details why you need a study to look for, quote, blockages. So if you're having active symptoms, chest pain, shortness of breath, then your doctor may recommend starting with a stress test. Usually they'll do it with either ultrasound guidance, so a stress echo, if you can get on a treadmill, or they'll do an exercise nuclear stress, exercise PET. They'll use a radio tracer to see if there's areas of the heart not getting enough perfusion. But if you need to actually look at the arteries and you have a contrast allergy, just because you have a thyroid condition is not a reason not to have iodine contrast if the risk outweighs the benefit, or I should say the benefit outweighs the risk. Now if you're having like hyperthyroid storm, then maybe they would not necessarily do it, but I did thousands of casts in my career, and this was not something we help people up from. Even if they had an allergy, give them steroids and monitor them. So it's not an absolute contraindication. Cardiac MRI is more useful for looking for cardiomyopathies, also looking at valves, but MRIs are not that great at looking at the coronary arteries directly. All right. Somebody says they were diagnosed with sarcoidosis. So I'm sorry to hear that. I do have some patients with that in my practice. It's not my area of focus, but it is a condition that can affect the cardiovascular system. It can cause a weakening of the heart. You can get a cardiomyopathy. It can cause heart rhythm abnormalities. The patient that I'm thinking of had a sudden cardiac death event and got a defibrillator with it. It is diagnosed with cardiac MRI and late gadolinium enhancement. Gadolinium is it's not contrast, but it's something that is used during MRI, and there's basically staining in the heart with sarcoidosis. It can also be picked up with a PET scan. So definitely, if you have sarcoidosis and it's more pulmonary, you need to work with somebody to make sure it's not involving the heart as well. So I don't see any other comments coming in. I'll hang out for a moment or two. But for those who joined, I just got back from an AI conference that the Mayo Clinic put on out in California. Outstanding conference. Some of the world's leaders in cardiology who utilize AI on a routine basis. I was figuring out what gear, tools that I'll be able to bring back to Apollo Cardiology. Some of them will be launched this week. Some of them I'm kind of, having talked to some engineers to help me with. But ultimately, the goal is that basically Apollo Cardiology be an AI focused practice. I'd like to have Apollo AI at some point, basically a virtual version of myself that I could interact with as a chatbot and would be able to interpret certain imaging that I would like to do for patients. So let's see. Did somebody put a question here? Causes for chest pain upon waking up, microvascular disease, hypertension, surges, cardiac arrhythmias, AFib, paroxysmal supraventricular tachycardia, ventricular tachycardia. So chest pain does need to be monitored and get worked up. So EKG, echocardiogram, monitor, if you have other risk factors, then maybe stress test, but don't ignore chest pains. Can periodic fasting of 24 or 48 hours provide benefits for preventing cardiovascular disease? Probably not preventing, potentially helping with people who have significant insulin resistance, may help with that, may help lower inflammation, but will not necessarily prevent cardiovascular disease. Cardiovascular disease is more multifactorial. And again, it's about the glycocalyx. If that layer gets damaged from pollution, heavy metals, plastics, high blood pressure, high blood sugar, high insulin, oxidized lipids, high uric acid, high homocysteine, those are just off the top of my head. There's 400 different things that can damage the arteries. Fasting is not going to fix all of those things. All right, so still waiting for some more comments or questions to come in. So back to the AI analysis. I was telling people that the AI EKG software is pretty slick. Can tell you, your basically your vascular age. And if your vascular age is increasing more than your biologic, that's a problem. There's software that's going to be able to analyze your voice. It can tell if you're an AFib, tell you have aortic stenosis. That's going to be pretty slick. Basically, you just talk to your phone, it'll tell you if you have a vascular problem. Devices that can listen to coronary blood flow from your heart externally, reasonable area under the curve and positive predictive value that would you have significant coronary disease. So 10-minute test that you do non-invasively. So I'll be looking at this. There's one company that sells the device. I got to set up a demo, talk to them, and see if I can acquire one. But I'm always trying to stay at the tip of the sphere to figure out what we can do to screen for cardiovascular disease, plus prevent it when we find it. All right. Causes for blood pressure swings from super high to super low is the next question. You'd have to think about some catecholamine surges, metanephrines, thyroid. A ambulatory 24-hour blood pressure monitor is the way to figure that out. You can do urinary testing to figure out if you have metanephrines that are elevated, and then a comprehensive blood work. All right. Then I was able to utilize Google's Gemini recently to put in some better descriptors for some of the archives I've done for these IG Lives, which I've been doing since 2019. My YouTube channel, which is just drtwyman.tv, has all the archives, or most of them at least, a couple hundred of them to be last counted. And I'm usually putting them up there within a week of when these get recorded. But they'll have the questions that have been asked and the answers. So if you're ever looking for the archives and Instagram deletes it, that's where that'll be. The other AI thing that if you followed my story today, that was Sora. That's OpenAI's new product where you can use AI to create photorealistic videos. I basically just made quick 15-second little videos just saying what ApoB is and nitric oxide. It did it on its own. So um, it's going to be a very interesting next few weeks and months that how fast some of this technology is moving. Next question tonight calls us for lipoprotein A to go up 60 points in a year. Depends if it's a woman, maybe due to lack of estrogen, so perimenopause or menopause can cause that. Inflammation can cause it to increase. And then the other thing is if patients started statin therapy to lower LDL, often times you'll see LPA increase, but your LDL particles decrease at a greater percentage than the LPA goes up. But usually inflammation or estrogen for women. Still no other questions coming in from the pre-submitted ones, so still looking for any more coming in the comments. If there are any AI questions, I'll answer those, but that's going to be my big focus. I'm in the process of recertifying for my cardiovascular boards. This year it's all about arrhythmias. Once I get that out of the way, then I'll get back to teaching myself more AI tools and how fast I can spin these up at Apollo. So if you're potentially interested in still working with us, we do have some slots still available. Most of them are going to be pushed out to next year. I think I'm booking into February or March next year already. And then for those that are going to be attending the Canyon Ranch retreat in a couple weeks, I will start after this board review is complete next week. Then I will start sending some messages to the Telegram group and email about my plans at the Canyon Ranch to do some fireside chats and teach you things that you want to learn about your mitochondria and your cardiovascular health. Do I recommend red light therapy at home? You know I have that at home, the person who asked the question. Depends on how you want to utilize it. So, at night, post sunset, I wear my blue blockers. I have red lights on in the kitchen and in the kind of dining room, living room area, so people can see when they're walking around. And then I do have multiple photo biomodulation devices, but I tend not to use them in the evening time. Sometimes, they don't necessarily affect my sleep, but if you use really bright red light at night from the photo biomodulation device, it may affect your sleep. So generally best to use those earlier in the daytime for most people. But the key is, bright light during the day, darkness at night, yin yang. Next question, can a lack of estrogen cause cardiovascular disease? It can contribute to it. It can affect LDL clearance. It can affect nitric oxide release from the endothelial lining. So it can contribute to accelerating cardiovascular disease. And this is one of the thoughts on why women do have cardiovascular disease generally about 10 years later than men, is that they're protected with estrogen. And side note for guys that might be on testosterone replacement therapy, if you're working with a provider who's recommending that you're on anastrozole or other estrogen blockers, you probably need to ask them why, because estrogen is very protective to the man's vascular health as well. So I don't usually recommend people block their estrogen. I'm not prescribing testosterone, so I'm not the person prescribing the estrogen blockers, but you need to really be aware that it's probably not good for your cardiovascular system. All right. Somebody says that they used to see me back in 2022. Well, give the ladies a call, and we can see if we can get you back on our schedule then. What are the levels of LDL if no cardiovascular risk for a lean mass hyperresponder? And then the triglyceride HDL ratio is low. I know everybody looks at that. It's a very, very rough estimate of your insulin sensitivity. You also have to look at small dense LDL, VLDL, look at the actual insulin levels, OMA-IR scores, adiponectin in some people. they really get a pattern if the person really is insulin sensitive. But I've ad nauseum talked about lean mass hyperresponders on different podcasts, and in my school group, I just did a 1 hour long Zoom call with them the other week, and that was one of the major topics was the lean mass hyperresponders. Don't really have an LDL goal that would be any different than somebody else who may or may not have vascular disease. It's all about how much plaque you have. So attack the plaque. If you have a positive calcium score test, abnormal clearly scan, known coronary disease, stents, bypass, you've had a stroke, you have plaque in your carotid arteries, you have an abnormal CIMT, lower is better. How low on an LDL-C? Well, depends, but in LDL-C, probably at least less than 70, and if you have other risk factors, potentially less than 55. But LDL-C is not the whole story. You need to look at the lipoproteins. So we look at the LDL particle count, generally being less than 1,000, and ApoB generally less than 70, but you can tailor it based off of things you can find in the Boston Heart Lab panels, but particularly you're looking at plaque. More plaque, treat the plaque. Is sarcoidosis parasites? No, it's an autoimmune condition. Do I recommend hormone replacement therapy for women with heart issues? I would not say that I recommend it. I can support it. I do not prescribe hormones myself to either men or women. It's outside my area of expertise. But if a woman is very symptomatic from low estrogen, they should talk to their primary care doctor, the OBGYN, or if they're lucky enough to have a expert in hormone therapy, and then talk to them about the benefits of going on it. There are some women that the risks are higher. If they have a history of blood clots, they have a strong family history of breast cancer, they're going to have to, weigh the pros and cons. But I have many, many women that I take care of that are on hormone replacement therapy and are doing very well on it. And I did mention the school community a minute ago. My school community is where I'm putting more long form content, talking about the Connect QT blood pressure monitor. I'm starting to put together a series on home screening devices. I think that's absolutely going to be the future with AI, is monitoring your vascular health at home with sleep trackers like the Oura Ring or a Garmin watch. There's all sorts of other toys I have that can monitor blood pressure and pulse wave velocity and nitric oxide that I can use at home already. So I'm teaching people how to utilize that in my practice, but I'm also teaching people in the school community how to do that. The school community has a free 7-day trial. Look at it, check it out. There's some courses I have in there on how to read your own labs. You can look at the prior like AMAs that we do there, which people log on to Zoom and we can go through some of their stories. So if it makes sense to you, stick around. That's where we're going to be doing a lot more long form content, and people can help each other and teach each other. So I think that's my role as an educator. Is I do a lot of one-on-one at Apollo. I do one-to-many through Instagram, one-to-many with podcasts, but the school community is where I can do it to kind of a more select group of people who are really interested in these topics. So if you're wanting more data or more things that are like this, it's just drtwyman.com/school, or if you look in my bio on Instagram, there's links there to the school community. It's Becoming Heart Attack Proof is the name of it. So I'm not seeing any other questions coming in tonight. So I'll log off here in just a second. Every Monday, 6 p.m. Central Time, I'm here helping you guys, try to become heart attack proof. So hope you guys have a great week. We'll see you on the other side.